Nice to see you. Oh my. I'm Dr. Céline Gounder. I'm the editor-at-large for Public Health at KFF Health News. I'm also a CBS News contributor. My fellow panelists here today include Courtney Haupt, who is the Global Chief Operating Officer and U.S. Chair for Health at Edelman. Kirsten Bibbins-Domingo, who's the Editor-in-Chief of JAMA and the JAMA Network. Richard Barron, the President and CEO of the American Board of Internal Medicine. And finally, but not least, Jerome Adams, the Executive Director of Health Equity at Purdue University and the 20th U.S. Surgeon General. Our panel represents multiple points of view: the general public through polling at Edelman, science and scientific publishing, professional societies and clinicians, government officials and policymakers, as well as the traditional news media. So, coming out of the COVID pandemic, we find ourselves in a real crisis of trust in the health system in the United States, as well as in many countries around the world. Many Americans do not trust the information they're getting from our government leaders, from health officials, or from the media. And many are turning to alternative sources of information, much of it mis and disinformation, very much to the detrimental impact of their personal health and their community's health. So to help inform our discussion, I'd like to share some stats from a poll conducted by my colleagues at KFF, formerly known as the Kaiser Family Foundation, just over a year ago on health misinformation. And I do want to note that there are some bright spots and reasons to have some hope, which might also help us prioritize some of the work ahead. So some of the key findings: 95% of both Democrats and Republicans report trusting their personal physicians to provide the right recommendations about health issues. Most people have a fair amount of trust in the government to provide accurate information about health issues, but trust does vary across political parties. Almost 90% of Democrats reported trust in the CDC, compared with about half of Republicans. State and local public health officials were trusted by almost 75% of Democrats and less than 60% of Republicans. And while exposure to health misinformation was rampant, the percentage of people who had heard false claims and believed those claims were probably or definitely true ranged from 14% to 35%. A key takeaway is that people, yes, they are hearing misinformation, but not many are convinced that it's true. The results suggest that many people fall into some sort of movable middle where people hear or read incorrect claims, but they're uncertain as to whether the information is accurate or inaccurate. Almost 90% of respondents believe misinformation is a major problem, and almost 75% specifically reported that health misinformation is a major problem. Most, regardless of their demographics or partisanship, also said that not enough is being done to limit false claims about health. Almost 80% reported that Congress was not doing enough to reduce health misinformation, and about 70% reported that President Biden, the news media, and social media were not doing enough either. And yet, people don't have a lot of trust in what's reported by the news media or what they find on social media. They're consuming traditional media. The traditional media that they truly rely on tends to be local and national TV news, like CBS, where I work, and only about a fourth of those have a lot of trust in health stories reported by local and national TV news. Further complicating the situation, people don't agree on what constitutes real health information. One person's misinformation can be another one's truth. Courtney's team at Edelman has been conducting complementary polling on trust in health. Courtney, could you share some of those key findings with us?
Yeah, and a lot of it really builds on what you've been sharing just now. Edelman's been studying trust for 24 years, and we do it annually with a survey that looks across 28 countries. 3 years ago, we started doing a deep dive report into health specifically. And what we found is we looked at 4 major institutions. We look at government, business, NGOs, and media. When we asked them, who do you trust from the institutional perspective to really do what's right for health, we found that now media, government, and NGOs are all in distrusted territory. Business is in neutral territory, but interestingly, a pullout of that, my employer, is the one institution that is trusted to do what's right by a majority of respondents. And why is that? We really wanted to dig in, and there's really 5 themes that I just want to share with the group that really pick up on these pieces here. The first one is the impact of politics, which in a year of global elections, I think is really top of mind for all of us. We asked people, and 2 out of every 3 people feel that polarization has had a negative impact on their health. We know that when we asked people about their biggest fears related to their health, the politicization of medical science is now on par with affordability and even a step slightly above fears about another pandemic. So it's very top of mind. And just to put a finer point on it, when we polled people about politics and their provider, we found that the 55% of young adults, when we talked about 18 to 34-year-olds, say that they would stop seeing their provider if he or she had different political beliefs from them. And we don't believe they're asking them about their political persuasion. They're making judgments on information and word choice and recommendations and assigning political belief to that. So the second trend then becomes misinformation. And I think the fears about misinformation, we now know when we think about barriers to health, cost and access have always been the top 2 ones. Misinformation is now number 2. Cost is 1, misinformation, access to quality information, that is sitting in that second barrier spot, and access is 3rd. And then we know also when we asked people about misinformation in their own life, we found that 4 out of 10 said they regretted a decision they'd made based on misinformation. And when you look at young adults, again, 18 to 35, this spikes up to 55% who say they've regretted a decision, which is actually a bit of a bright spot because at least there's a recognition right now. But as we think about decline in media, decline in trust in government, people are now looking for information in different ways, which then really comes into play on who are you trusting. So I would say that as we're thinking about a rise in empowerment, another piece, empowerment is such a good thing, but when it comes to finding information, if you don't have trust in the system, it leads you to being a skeptic. And so we're finding people more and more looking for information on their own. 1 in 3 adults surveyed and 48% of 18 to 34-year-olds say, I can be just as informed as a doctor if I do my own research. And we know they're mostly doing that research online from sources, and they may not be verifying that information. So we really need to close that gap, which does bring us to 2 bright spots. The first one is the rebound in trust in the physician. This is a really welcome change because what we saw last year was a rise of 11 points in trust in friends and family as health experts. What we've seen this year, friends and family have actually declined somewhat. They're still trusted, so we still need to think about this as an important audience, but the physician audience has risen back up. So when we ask people, who is responsible for helping me, has a big impact in making me healthier? Number 1 is myself. Number 2 is my doctor. All other groups, including government, employers, NGOs, have declined. But when we say, who do you trust to help me think about what I need to do to be healthy? Again, my doctor is number 1. Who do you trust to give you guidance on public health guidelines? Number 1, my doctor, well above national health authorities. So we really have to think about the power of the physician audience here, broadly defined. And the number 1 thing I will say is my doctor, even more so than doctors in general, is that real trust. So people are really looking at their doctor. And the last sort of bright spot I would say is that if we think about information, the number 1 way for institutions to build back trust in health is to provide high quality, accurate information. And that holds true for business, government, and for NGOs. So a place we can dig into more. I think there's a lot of caveats around how does that information get out? Do we put it on the right channels? Are we doing it with trusted means and the right messengers? But there's such power in information.
Can I jump in super quick on a couple of points you made? Number 1, I wrote a report when I was Surgeon General called Community Health and Economic Prosperity. And it was a report unlike any report ever from the office before because it wasn't written for a health audience, it was written for a business audience. It was making the case that businesses need to get involved in building healthier communities. And what struck me from your report was that people said my employer is more trusted than the media, than NGOs, than government in terms of health information. So I was talking to a group of young CEOs who were here at Aspen this morning, and I implored them, use your influence to be able to improve health. You don't have to tell people to get vaccinated, but you can have information about vaccinations and help them understand how they can get vaccinated in your community or in your workplace. Incredibly important that we understand the role businesses play because most adults spend most of their lives at work. That's number 1. Number 2, you mentioned people with different opinions based on their perception of doctors. This is a funny story that I talk about in my book. And they told me, Aspen told me, I'm doing a book signing later. They told me to make sure I tell you all that I wrote a book and that I'm doing a book signing after this. But I talk a lot about relationships during the pandemic. And Tony Fauci and I would get together every night and we'd discuss what we were going to say on the media the next day. We would literally speak from the exact same talking points. I can't tell you how many times I would watch the tape, say the exact same thing. If Tony said it on Fox, he was the devil. If I said it on Fox, it was great. If Tony said it on MSNBC, he was a god. If I said it on MSNBC, I was the devil. We were saying the exact same things, but it speaks to your point that when people perceive that you believe one way or the other politically, it tilts the way they take in the information. And we have to appreciate that and figure out how to address that, which leads to my final point. This is the most important point for you all to take away when it comes to trust. Why do people trust their doctor? Why do people trust their employer? Why do people not trust someone who doesn't subscribe to their political beliefs? Why do they not trust Tony Fauci or me, but they'll trust doctors? People need to know that you care before they care what you know. And if you don't create that relationship, that connection, and if they don't think you care, they're not going to give a damn about what you know. They're not going to listen to you. So really, it's about creating relationships so that people then will listen to what you have to say because they truly believe you're saying it in their best interest and not because you have a different agenda.
So Kirsten, Richard, and then Jerome, why does it matter that people are hearing mis and disinformation? What exactly is the problem we're trying to solve? How would you frame it?
Great. That's exactly the right way to ask the question. I think of, we call it the movable middle, but I think of the large number of people in the US that just have poor quality information. They don't have the pieces of information that would help them make their own decisions. I don't think of it as I need to tell them what to do. I think of it as this is the perspective I now have as a journal editor, is that I want to be part of giving the high quality information to someone so that their physician, their clinician can make decisions together. So that to me is underlying that. Within that mass of poor information, there are political forces that want you to shift information one way or the other. That is oftentimes, they want to distort information. That's oftentimes what we call disinformation. But I think it makes us not appreciate that many, I would even say all of us here, there is a deluge of information. Much of it is not high quality information. There is a lack of ability to fully figure out what is high quality information, and that is the fundamental problem. And I frame it that way because the political debates are important, the disinformation is important, there's a lot of reasons we all should be concerned about it, but as people who care about communication of high quality information, we mostly want to fight for that middle and figure out how to continue to give high quality information to everyone so that they're able to help make the best healthcare decisions.
And of course, we're talking about health information. We're talking about people making choices that can be life and death choices. And if they're making those choices based on bad information, they're making choices that may not be very good choices. I completely agree with Jerome that doctors need to create relationships, that's a critical part of what we do. But I think there's something that sometimes gets lost in the conversation. That trusted role that doctors have, they have that because they're members of a community
yes,
of other doctors who have validated that expertise. Science is not an I, it's a we. I can have a great idea. I think that I can cure cancer with daffodils. And in these days, I can put that out there, I can sell that, I can create transactions around that. But what the community of modern physicians have committed to is a knowledge generation method. And that method, it has its flaws for sure, and it has its limits in application. But it's fundamentally a statistical method that says, if you do X, you're more likely to have a better outcome than if you do Y. That doesn't mean that everybody who does X is going to have a good outcome. It doesn't mean that everybody who does Y is going to have a bad outcome. But with varying degrees of certainty, that choice is a very consequential choice. And the role doctor, as it gets awarded in this society, is people who are trained in that methodology, and then it gets channeled into journals, which rely on the same methodology to create the standard we all use to practice, to government agencies that try to channel that. And we're all building on that method. And what's happening now is people just can make stuff up, and they put it out there, and as that famous New Yorker cartoon has the two dogs in front of a keyboard, what I love about the internet, on the internet, nobody knows you're a dog. And I think that is the world that we are in right now, and it's a pretty critical set of issues to get out there.
I couldn't agree with you more, and the challenge, and maybe we'll get to this later, is for me, many of you all know I have a very robust online social media presence, and I will engage with folks. And the challenge is you will have actual legitimate MDs and DOs online saying things to me and in general that they would never say at a meeting, that would never make it into a journal article, but they're saying it using that authority of MD. And so one of the questions that we have to figure out is how do we adjudicate the online presence from the official presence? And it's challenging. Those two, thank goodness it's their job and not mine. But you asked, what is the problem? The problem is that according to a recent study that was published, 200,000 people died because of misinformation and mistrust because they were unvaccinated for COVID. So to your point, Kirsten, people are dying, number one. Number two, we're at record whooping cough cases in the UK. Vaccine-preventable diseases are coming back, and that's hurting us in so many ways, not just deaths, because most people aren't going to be scared if you're going to die, but missed school and increased healthcare costs and all the sequelae of a vaccine-preventable disease. It's a national security issue. So I remember one meeting I went to in 2020. I had to present at the Indo-Pacific Chiefs Conference. This is all the military people in the Indo-Pacific. And the challenge was the US had such a high COVID infection rate that a lot of our strategic partners were like, we're not going to let you bring your ship to our island nation and infect our entire island nation. It is a national security issue. So we need to understand this is more than just about your choice to vax or not vax. It's not an individual thing. It's a collective problem when we see the return of vaccine-preventable diseases. And beyond that, when you have a salmonella outbreak, and the CDC says, don't eat lettuce. Well, you can't trust the CDC. I mean, that's what people say online. And if you don't have trust, then you're going to see people continue to be harmed. And that's why this is truly it's a global crisis. The WHO and the current Surgeon General have both said misinformation is a public health crisis, and it truly is. It's not just about the individuals, it's about our society.
Kirsten, one of the findings of the Edelman polling is that patients want more from their providers than straight-up healthcare. They want to be able to vet information and public health policies with their provider, but that seems like a heavy lift for providers who are increasingly rushed to see more patients in less time and who are shouldering increasing administrative burdens. Can clinicians' time be bought back, so to speak, to allow for this? How can clinicians be incentivized and evaluated on whether they spend? Because you're the smartest one. But how can we empower them to actually do this? You know, we keep trying to pass off more and more responsibility to the frontline provider, clinician, because they are so trusted.
Yeah, exactly right. Yeah, I think that's right. I think part of the reason, and this is sort of riffing off some of the things that were already said, the reason we trust our doctor is in part because of the expertise and in part because of the relationship and the ability to have the conversation. I'm a general internist, a primary care doc. I take care of a lot of patients who don't believe the same things I believe. I have no problem having conversations with them. I have no problem. You don't like the statin I want to give you today? Well, we'll talk about it next time. And over time, you start to see, well, why is it you don't like that? Well, okay, this is how I think about it. This is how I see the science. The question is how to scale that. That I think every physician, every clinician has that experience. They know what it is to meet someone where they are, to meet someone who thinks differently, to engage over time. That is why patients come back to doctors they trust, clinicians they trust, because they can ask those questions. And so we do have to carve out that time. One of the things we decided at JAMA is that, we're publishing for scientists who are advancing the field, we're publishing for clinicians, we're publishing for patients, for health policy leaders, for other decision makers, and that if clinicians are a trusted source of information, one thing we have to do at JAMA is to also give clinicians all the tools they need. So science is complex. Science is always changing. There's nuance that's difficult to communicate. There's a whole science of communication. And so we've started a series recently about just helping to bring the best tools for communication to the people who are communicating, because we want to give clinicians more tools. They already have a lot. They need more time, but we want to give them the best tools based on the science in communication. The other thing we're trying to do is to realize, there are a lot of ways that we all get our information. We are all overloaded. There's a reason we listen to podcasts and we read less. There's a reason that we are on our phones looking at the soundbite. There's a reason we want the bottom line summary from the daily because we didn't read the full New York Times. There's a reason that all of that. And so journals and other sort of health communication medium have to be in that same game as every other modern communication entity. They have to be doing podcasts and videos and using graphic explainers and doing short things, framing things in different ways for different audiences who might come at an issue in different ways than just, JAMA published this trial, so therefore you should do it. That's not the way we do things anymore. And so definitely, solving the problem of more time in primary care is way bigger than I can do on this panel, but I think giving more tools to help busy clinicians and busy practices to help patients engage in the conversation is really part of the issue.
You used two different words, and you switched, and I suspect you switched intentionally. You asked about doctors. You said clinicians.
Yes.
In the trust polls, and we talked about doctors, in the trust polls, nurses are actually more trusted than doctors, and pharmacists are just behind nurses. So one of the things we can do is leverage all of our providers more effectively. Most people go into their CVS or their Walgreens or their Kroger or their Walmart far more than they go into their doctor's office. So how can we leverage pharmacists to actually increase information transfer and knowledge and use that trust base? And I like what you said about tools. CDC, I was a health commissioner. One of the most valuable things the CDC did for me as a health commissioner were the pamphlets and the posters that they would give for doctors' offices that we could distribute, where people are sitting in the waiting room, and you can use that trust not on the doctor's time, but while they're sitting there to absorb appropriate information. How can we use video graphics? And I'm looking at Blythe out there. Blythe is working in AI. How can we use ambient AI and different technologies to actually take some things off the doctor's plate so the doctor can get back to actually looking at and talking to the patient instead of typing on the computer with their back to the patient the whole time?
Richard, are credentials enough to build trust, or do healthcare providers also need to be able to back what they say with the data? Speaking to what Kirsten is saying.
Certainly, credentials are not enough by themselves to build trust. And I think most people, when they're seeing a clinician, just assume the person has the credentials that they need. But that's important because these days there's lots of clinicians out there who don't have those credentials, and I think it's important to pay attention to that. I do think the relationship piece is critical. The data piece in the context of a relationship is critical, and building on what Kirsten and Jerome just said, I think we're not going to make more time. We're not going to make more time for doctors. I was in community practice for 30 years, and it was a challenge of realizing that I wasn't always going to be there when the patient showed up with whatever problem they had. And we were an early adopter of electronic health records in our community practice in 2004, and the problem we were trying to solve was that. We wanted we wanted to know what our partner said to the patient the day before, which on paper we had no way to know. We didn't. So I think we need to get better in healthcare at scaling trust. And I think technology can help us do that. When you get in an Uber, you're trusting something. What exactly is it that you're trusting? Are you trusting the driver? Are you trusting the app? Are you trusting the company? But there's been a lot of investment and thought on the part of that company in how to create a world where people will get in a car with a stranger and go somewhere. And I think that in healthcare, which isn't to say we want to get rid of the personal relationships, we don't, they're going to be the core of it, but we can do a lot more intentional use of technology to make ourselves be more trustworthy than we are right now.
And just a follow-up question for you, Richard. Do state licensing boards, professional societies, healthcare institutions, do they have a responsibility to de-credential healthcare providers who provide mis and disinformation?
I want to know the answer to this question.
Yeah, Céline, you're asking about, I'm the CEO at the American Board of Internal Medicine. You hear the expression board certified. We certify 1 in 4 doctors in the country. And we announced that if doctors put out flagrantly incorrect misinformation, that if patients relied on it, they'd be injured, we would consider revoking their certification based on that. And that put us in the middle of this whole freedom of speech, and all of a sudden everybody's Galileo, and all of a sudden we're the Catholic Church, and we're censoring, and and again, as I said to an oncologist who said, well, we have passionate debates about the right way to treat breast cancer. Is the board going to jump in on that and say this one's right and that one's wrong when we don't know across the country? I said, no, that's not what this is about. But if you saw somebody who'd been treated with magnets for breast cancer for the last year, would you regard that as just a good faith difference of opinion? And that's not the issue. We have a very powerful way of generating reliable information and reliable knowledge. And when people completely disregard that and make stuff up, I think it's on us and other healthcare institutions to say, I'm sorry, that's just not okay. Thank you for that, because we're in court defending the proposition. Yeah. and frankly, in the very same court that the Missouri versus Murphy is about whether somehow by trying to articulate professionally defined standards of care, somehow we are being accused that it's government censorship and we're colluding with the government. And basically, that's not our view.
And a lot of that is, oh, go on.
I think Rich and the ABIM has been really at the forefront of this, and it is so important, especially if people trust their doctors and their doctors really are advocating for things that clearly is not science-based. The challenge for thinking about trust and science is that science is often nuanced. There is often uncertainty. Science builds. When people say, oh, well, that study is now, we now see that study arrived at a result we no longer have confidence in, that is part of science evolving. That is like part of the design. And that is a challenge for all of us who believe in the scientific method, who all of us believe in the importance of high quality information, is that it is oftentimes more complicated. And I think that is the challenge in all of this, for all of us trying to do this work. And I just want to acknowledge that as well.
No, you took the words right out of my mouth. It is a challenge because science isn't about always being right, but it is about always trying to pursue the truth and having the humility to say, okay, we were wrong. And it's why, even though everyone wants to stop talking about COVID, we have to understand how COVID accentuated this issue. So you had a lot of things that we thought were like literally law, medical law. Put people on ventilators, 6 feet, all these things that we then learned changed with COVID. And so I think that the challenge is that many people don't understand that science is about evolution, and it's because the United States spends more money on healthcare, has lower life expectancy, and that actually correlates with the fact that we also have lower scores on math and on science and statistics than most other countries. So one of the things that I actually say in my book that we need to do is work on educating the public better about the scientific process, because we can't have these conversations if people don't understand. But we also have to own how much science, and I'm going to be controversial here, how much science was sometimes weaponized in 2020. We had a pandemic superimposed on top of a presidential election. And there were things that were said in the name of science that caused people to lose trust in science. And I want to tell you all a really quick story because it proves the point. Donald Trump, about this time in 2020, said he was going to hold a rally at Mount Rushmore. You all remember that? People lost their minds. And I had to go on the news. And this is the way I was introduced. Donald Trump wants to hold a maskless rally. Our experts say thousands could die. Coming up next, Donald Trump's Surgeon General to explain. And that's the way they would introduce me. And so again, you're already tilted from a bias standpoint. Here's what I said. I said, look, I want people to understand their personal risk. Are you old? Are you young? Are you diabetic? Are you not? I want them to understand the environment they're going into, indoors, outdoors, masked, unmasked. And then I want them to make a choice that's right for them. I got ripped to shreds by the public health and medical community for not condemning Donald Trump's rally. What else was going on in June, July of 2020? Black Lives Matter rallies. And if I went on CNN and condemned people going to see the President of the United States, I was going to have to go on Fox News the next day and explain to Sean Hannity why the virus cared that you went to a Trump rally, but the virus didn't care that you went to a George Floyd rally. And we lost a lot of trust on the part of the public and in science because science was weaponized for political reasons. And I think not all of it was intentional, but if we don't acknowledge that, we're never going to win people back. We're not going to.
And Jerome, I was on the receiving end of those very same questions. Also, what was happening in Fort Lauderdale at the beach. You know, having people outside, that's actually what you wanted. And so it was a very interesting position to be in where we were being asked these loaded questions where there was clearly a right answer and a wrong answer. And I think those of us who are true scientists drew on the real science. Courtney, I want to turn back to some of your polling, grounding our conversation in evidence. Ultimately, good health depends on trust in health information, but it also requires patient empowerment. And I think that's a piece that we often miss. What did your polling find about that? And what can be done to better empower patients?
So it was so interesting. We saw that rise from 2 years ago and people looking for information themselves, trusting what they were finding themselves, and we wanted to dig into that more. What we really found was this very interesting relationship between trust and empowerment. 4 out of 10 people said that they were both empowered and had trust in the healthcare system. Globally, 2/3 of people, globally in all the countries we survey, say they are empowered when it comes to their health. They know what to do, they feel they can ask somebody, they can stand up for their healthcare needs if someone gives them a recommendation they don't believe in, but they know where to go for information. But what we found is that if you look outside of this group, the group of people that have trust and empowerment, they have self-reported health outcomes on the scale we were looking at that were about 19 points higher than all of the other mindsets. So we really do see that if you trust and you have that empowerment, you are going to do the things you need to do to be healthier than other people. If you have empowerment but you don't trust, you sit in this skeptical group. You know how to go find information, you've got it covered, but you don't trust the health system because of your experiences, because of whatever's happened to you and your family. That group is a really concerning group because they're out there on their own, and if we can't bring them back in and convince them the system can work for them and we show them how that works, they're going to stay out that way. You also have this group of people who have trust in the system, but they don't feel empowered. That's that group that has 19-point less better health outcomes, but that's a group we can reach. If we can find that group, what we need to do is help empower them because they already have the trust there. And then, of course, we have the group of people who don't have trust or empowerment. And so what this really says to us is strategies have to fit all of these mindsets. We have to be tailoring communication strategies and engagement strategies to meet all of these different groups where they are. That takes a lot of effort. So it really takes partners to be working together to think about how we can do that. But if we do it, the payoff is there because that trusting and empowered group, they have better health outcomes. They will be your advocates for guidelines. They trust health innovation more. They will advocate for other issues, and they'll share that with their peer set. And that's really what we need to do, is to reach in and make sure that they're helping to spread the word, in addition to people talking to healthcare professionals and other experts.
And
I want to
Courtney,
tee up Rich real quick, because you talked about the low trust, low empowerment. You have to ask yourself, where are those people? Well, those are people in many cases who don't have a clinician, who don't have access to care, who don't have health insurance. They're people who live in the rural South. They're people who live in states that did not expand Medicaid. And so it's incredibly important that we understand that it's hard to feel empowered and it's hard to trust the healthcare system if you don't have that connection with a trusted clinician. And Rich, I don't know if you have thoughts about that, but I think it's incredibly important that we acknowledge that if we're going to say we want to address the health gap. Interesting thing about the pandemic, our vaccine distribution was unlike any other vaccine distribution in history. We said, come to the stadium, stick your arm out the window, and we're going to stick a vaccine in you. You had to have already had the decision made based on what you read online or heard on TV before you'd come in to get vaccinated. We took away that opportunity for people to have that conversation with their clinician before they got vaccinated. And I think that was a problem. But again, how do we create that connection when people don't have access to care?
I think it is possible to create healthcare delivery systems that prioritize the building of trust. Toyin Ajayi, Dr. Toyin Ajayi is here. She's at City Block. The entire organizing concept there is we're going to start with community and we're going to deliver healthcare in community channels. It prioritizes creating relationships as the first thing, as opposed to the first thing being, let's get that proton beam thing to knock out prostate cancer, for which it is not helpful. So I think it is possible to do it, but it's a matter of focusing on trust building as a consistent attribute. And we use the word trust and trustworthiness, and it's, I think, really important to separate those. That trust is what we're hoping patients will have in us. Trustworthiness is how we'll behave as a system to deserve that. And if we're going to behave in ways that don't deserve that, which at scale across this country we're doing a lot of that, we shouldn't be that surprised when people say, I'm not going to trust what you're offering me.
I want to come back to Courtney for a moment. You have advised companies, health associations, NGOs on ways to build back trust. What are some of the actions they've taken to do that?
Well, so on the information front, when we think about how to communicate, I think we think about, from a communications lens, the word choice you're using. How do you have content that's both data-driven, but also has empathy and really meets people where they are?
And it's culturally appropriate.
Absolutely, and I think understanding your audience and the communities and all of the issues that they have that we really need to address is so critical. We did some really fun work with Johns Hopkins and the Bloomberg School of Public Health, and so just from the public health lens, trying to make some of the science both fun but informative. And I think when you see some of the work they did on their social channels, being able to really shift a mindset of how we can talk about science online in a way that's super informative, but also really uses a more lay approach to really reach people really resonated. We're also doing campaigns on public health issues with a variety of organizations and really thinking about how do you laser in on those audiences, but thinking about not just the audience you want to reach, but all of the people around them, because we know they're going to ask questions to self-vet this information. And if we can't reach their families, if we can't reach community leaders, if we can't reach religious leaders as well to arm them with the right information, they won't believe what they're getting. So campaigns really have to be multifaceted. A mental health campaign that we're doing with the American Psychiatric Association and their foundation is a wonderful example of really looking at personal stories and data to help people who already think they may need to get help understand what are the steps that I can take to take the next step to get help. And so I think programs like that can be emulated broadly. The last thing I'll say is healthcare workforce is such an important part of this too, both thinking about the next generation of people, if we're thinking about trusted clinicians, but also existing and current people in the profession. And how are we really reaching them to help make sure we're bringing in all of the people so that the communities and the public really see people they can relate to and whose information they'll trust. And a lot of the professional societies right now are really thinking about those issues. How can we make sure that next generation wants to continue working in healthcare with all of the challenges we know are on the front lines?
Kirsten, I'm going to give you the last 2 minutes before we open it up to Q&A. I think you were going to say something.
Well, I just wanted to acknowledge, the wonderful result about empowered patients. I do think we just have to also, that is not always patients who are agreeing with what we're saying, right? That's not, to me, the patient I worry about is the patient who's not going to come and engage with me in the conversation. I'm not worried about the patient who's going to tell me or question me or whatever. I'm worried about the patient who doesn't talk, because that's a patient who probably has a question, is going somewhere else to find the answer. And I do think we want to acknowledge that there's a lot we also don't know. And I think there is a lot we as clinicians have always learned from our patients. There's a lot that an empowered patient knows about themselves and can help us as clinicians in helping to find the best the best treatment for a patient. And so I think it is sort of recognizing what that actually means in practice. It isn't to say, we throw science out and it's like whatever anybody wants, we'll just talk about it. It is, we do have to understand what the scientific basis for our medical decisions are, but then engage, because healthcare is ultimately still personal for individual people, and that's at its core is what we'd want is an engaged patient to be thinking with us about what's right for them.
And one more grenade to throw in before we open it up for questions. That's what really concerns me about all the vitriol out there about DEI. Because you can't be empowered if you go into the healthcare facility and you don't feel like people are listening to you. So I put out a call to action on maternal mortality when I was Surgeon General of the United States, and we found that Black women with PhDs were more likely to die during childbirth than white women who hadn't graduated from high school. These are people who are empowered in their day-to-day lives, but they didn't feel empowered when they encountered the healthcare system. They didn't feel like they were listened to. And the CDC has a He or Her campaign that's teaching both people how to speak up for themselves in difficult environments and also teaching healthcare providers. But how does that relate to DEI? Racial concordance, it actually does matter statistically in a lot of situations. And there are fewer Black males, for instance, graduating from medical school now than what there were 40 years ago. Which is why when people ask me, how could you serve that administration, my answer is easy. How could I not? How could I not when I realize how few people who look like me have had that opportunity? But also, we need to make sure we're increasing the pipeline so that our healthcare workforce looks like society. And we also need to make sure, we need to understand not everyone's going to have the luxury of having someone who looks like them. So how do we train individuals to work with diverse populations? I do a lot of work with the LGBTQ community. Even though I don't personally identify with them, I've learned how to speak in a way and conduct myself in a way that makes them feel included. And that improves their health outcomes. It's been shown to. So we need to make sure we don't get rid of the conversation and the training and the workforce issue, and addressing the workforce issues that are going to allow patients to feel empowered.
All right, our audience. Let's see, the woman with the striped shirt over there.
Hi, Karen Landman, health reporter at Vox. Thanks so much for this great session. I wonder if there is any way in which you would ask consumers of health information online to take some responsibility for how they consume that information and what you might ask them to do differently than they're doing right now.
And who are you directing the question at?
Really, anybody who wants, I don't know if this is okay, but if anybody who wants to respond, thanks.
I don't think any of us feel great being in the business of telling consumers and patients what to do, but credentialing information, knowing its provenance, knowing its source, I think being careful about what's the source of the information you're getting, and that's harder and harder to do. And at least with Google searches, for instance, you're going to a place, as people start using large language models, you're not even getting a citation, you're just getting some answer. So I think that's going to get worse before it gets better. But I think being pretty disciplined about what's the source of this information is a really important place to be.
Source and what's funding it.
I
think
is just as
source and
important.
what's funding it, that's important. But I do think that organizations that are giving out high quality information have to understand we're in a marketplace of lots of stuff. And so when I talk to the head at YouTube, Garth, he says, yeah, we can tell you these are the trusted sources where the videos are coming from. The problem is that my videos or the videos from your institutions, they're like an hour long and they got a talking head. They're super boring. And all of the other ones, they're super interesting and engaging. So I don't need to be in the business of dumbing down ideas, but I need to know, consumers are consuming. The people who are good at this because they know what attracts attention, they know what messages get out there. And I think those of us who are in the business of trying to communicate high quality information have to be in that same business. There's no doubt about it.
I would also say,
Yeah.
again, this empowered and high-trusting individual, they are vetting. And we know the behavior is there. I mean, consumers are saying, I do vet information. Are they vetting it enough? Are they doing it frequently enough? But there's a behavior there that we can get them to do more of because they are actively searching and looking for information. I think it's giving some more of the guidance that's there. But absolutely, too, it's the kind of information I think we saw, especially with anti-vax content. There was a really strong way to do things in a certain way with language that made it very compelling. And when people have to mine through lots and lots of information that they're not really sure they know what the answer is or how to understand it, they can tune it out easily. So I think it's two pieces. It's vetting and then really clear information.
I'm going to say what Kirsten said in a different way. Public health and the medical community have long time had privilege and have been arrogant. And the privilege and arrogance has been that I'm the doctor, I know best, thou shalt listen to me. And I get a lot of flack for the engagement that I have on social media. And you know, in many cases, I was the first social media Surgeon General, and a lot of people said, you shouldn't be doing that. That's beneath you to be engaging with someone online on this topic. But Joe Rogan is going to eat your lunch every day if he's out there and you're not. TikTok, you've got to be there because that's the majority of people say they're getting the majority of their health information online. And so if you're not there, number one, then someone else is winning that argument. But when you're there, to your point, you have to make it marketable. You have to get rid of some of that arrogance and understand, I'm competing with Joe Rogan. And so I've got to frame this in a way that actually resonates with folks.
If you go into medical schools and public health schools, the students are getting their information on TikTok.
Yep.
If you're not on TikTok doing something that they know who the influencers are, they say, I trust this person, and there's a lot of high quality information. So, but that's reality.
Back to our audience. The woman with the red glasses here.
I love your glasses.
You
by
have
the
to
way.
wear something that stands out so
Yeah,
that it's easy to call
let's
on.
make a deal.
Thank you very much. I love my glasses, I have to say. Lena Walker, AARP, I love this panel. Thank you very much. My question is for all of you, but particularly the physicians on the panel. We know that the healthcare system is evolving, and when I hear the data about trust, it's really trust with your doctor. But in healthcare today, you're lucky if you have a physician, a primary care doc that you see on a regular basis. Yeah. Mm-hmm. You're now part of a practice. Even if you have good healthcare coverage, you're not going to see the same doctor. And, you might see a rotating bunch of doctors. And then if you don't have good coverage, it's hard to find a doctor. So how does that implicate the efforts to build trust within the healthcare system? If the system is evolving in a way that removes that personal connection, then what could be the mitigating factor?
I think we underutilize technology to create connections. And one of my friends hacked his EHR so that a patient who had a difficult to pronounce name, it said how to pronounce the name when the landing screen opened, and everybody in the practice knew how to pronounce this person's name. So I think there are a variety of ways that we could be using technology that we're not, that can make people feel seen and recognized and known and remembered. And I think we can also do a better job within healthcare acknowledging that that's a serious problem we have to solve with every encounter. And we can't just assume that we're going to have that trust and reliance.
I would also say I'm less worried about us working together as a team. I think then we have to work as a team. We have to communicate across the team. We have to articulate our standards for engaging with patients in a trusted way across the team. I'm more worried about this sort of what's another trend in healthcare of this sort of episodic, very episodic care, care only through technology. That's what I'm more worried about. I'm not worried about the team care because I think that can be done very well.
And doctors and health groups need to get out of the clinic and into the community. So you're talking about the traditional encounter, patient comes in, sees clinician. One of the things that I try to promote when I'm talking to healthcare practices is have a presence in the community. Go to the churches, go to the nonprofit groups. And when you're there as a group, then you get a chance for them to see you and to build that trust within you. I think that's yet another way when you're talking about evolving systems, we can also evolve them in a better way so that we're going to them instead of expecting them to come to us with technology, but also literally. So in Seattle, that I went out there to Seattle Children's during the pandemic, and vaccine hesitancy. What did they do? They had talked to the doctor, and once a week they would go out into the community, and people could come in and just ask any question of an infectious disease doc or a pediatrician who was there, and that built trust in an environment that wasn't the traditional clinical care environment.
One last question, 20 seconds each to answer. The woman in black at the very back.
Hi, my name is Sonia Eden. I'm a neurosurgeon from Oxford, Mississippi. It's a blessing to be here today. I wanted to ask a question. I want to know, do anyone on the panel, do any of you have any data on the misinformation, the sources people are using? Is there any differences based on race of these sources?
So I don't have race information, although it might be something from our research we could pull out as a follow-up, which I'd be happy to talk to you after. But I will say that when we look globally at the sources of misinformation that we found in our survey, the #1 source of information were product advertisements, but primarily knowing that those advertisements are coming online. So people are finding things. This could be wellness information. It could be other kinds of health information. #2, though, are friends and family. So this is a real place. And interestingly, in the US, friends and family is #1. The third source is user-generated content. So we're talking about videos, we're talking about things on social media, even comments in chat rooms. People are looking in like comments and reviews for health information. Anecdotally, someone said, I go to Amazon, I go through the reviews of things and I figure out what I need to do based on that. So those are the 3 places that we are seeing. I absolutely think that if we looked at it with some more granularity, we could look at some other places for specific communities that we need to think about.
We have a lot of data, but I don't have an answer to that question, and you've inspired me to go back and ask our team to look at it. Thank you.
I just want to thank our panelists for an excellent discussion. Thank you.